Hi everyone, my name is Dr. Lasker or Imran Lasker. I'm just going to share my screen quickly so that we can hopefully look at a few cases. So some of you may have come to previous talks and we've been going through a few plain films and kind of just sort of getting to grips with plain films. If you haven't seen those, it may be worth going back and watching some of them because we kind of went through a few plain films and then we started introducing a bit of CT. And this today is going to be a little bit more, I guess, yeah, CT heavy, I think. But we'll have a few plain films to help us go along. So hopefully you will have the link. I think Seidel has just put the link on there for us, and you can see my screen. So if you don't have the link, don't worry. We've got this. You can watch it on my screen, then hopefully just work through the problems together. So one of the things that I was always taught is that there's no point in just knowing the answer, right? Because knowing the answer is just half the battle. You need to know how to get to the answer. So hopefully by watching the previous talks, watching this talk, I'll give you sort of a framework as to how I guess a radiologist looks at scans. And if you guys are radiologists, maybe it'll help you. And if you're just interested in radiology, and maybe some of the cases are something that you'd be up for looking at. Right, so I'm just going to get this particular scan. So this is case number one. Unfortunately, just opened up in what do you call it, lung windows. Let's just go with abdominal pain to begin with, and I'm going to click on the scroll button. And also, if you are finding that things are going a little bit slow, click on that little cloud button, and that just sort of downloads it, and you can see that red button going right across. It shouldn't take long. Obviously, it depends on your internet speeds, and mine might be a bit slower because the kids might be watching Netflix. They're really getting into The Hobbit of all things. Okay, so right, so we are going to be looking at this patient. They have got abdominal pain. And for those of you that are being able to get through the scans quicker than me, then you just go ahead and write whatever you think is going on this study. And I'm going to work through it slowly, so that I understand that not everyone is coming in with the same ability. Some people are ST1, some people are even thinking about doing radiology in the first place and just very interested in looking at scans. So, which is a great place to be, by the way. Right, let's start from the top. We just have to kind of scroll through down a bit. And then one of the first things I always ask myself, because you're not always aware, is what phase of imaging is this, right? And if you look at the aorta, which is sitting over here, I'm just going to get the pen. There's a pen function over here, which is quite cool. So you see that thing over there, that's going to be the aorta. And that doesn't look as bright as the bone on this particular window. So therefore, this is not going to be an arterial phase image, right? And as you come further down, coming further down, you can see that the portal vein, which is sitting right over here, right over there, is slightly brighter actually than the aorta. So when it's slightly brighter than the aorta, then you must be thinking along the lines of this being a portovenous phase image, right? So what I normally do is this is what I'd highly recommend anyone to do if you're interested in imaging and reporting. Go right from the very, very top, go all the way to the bottom. Just look, just do one cursory look all the way down, all the way down, all the way down, all the way down, right to the very bottom. And you know, if nothing popped up at you, then that's fine. Now you've got to do the legwork and see what's going on. So we do have the chest images on this one, and I'm going to just change the window. Hang on, let's move that out of the way to the lung windows. And they've got abdominal pain. So one of the things may be, oh, have they got air under the hemidiaphragms, or they may have pneumomediastinum or something like that. But as you kind of scroll through, there's nothing like that. If you look at the mediastinum, which is this area over here, that actually looks okay. It doesn't look like there's anything going on there at all. Everything looks normal. And as you scroll further down, you may start to notice that when you look at the bronchioles or the bronchi around here, they look a bit thickened, don't they? I'm going to just zoom in and just show you what I mean. So zooming in, you can see that these look a little bit thickened and a little bit irregular. Okay, so that's something to think about. And as you kind of scroll through, there's all this kind of gunkiness sitting over here as well. And again, the bronchus and the bronchioles, as they go down, they seem a bit bigger than they really should be and very, very thickened. So you're looking at something that looks along the lines of maybe some traction bronchiectasis. So you've got these tubes, and then some of the lung parenchyma, because it's kind of fibrosing and pulling away, is pulling some of that tubing, and you end up getting sort of zigzaggy appearance. And on top of that, it looks like they've got a superadded infection. So there's lots of gunk sitting within the airways as well. So, I mean, that's a few things that we're already spotting here. So if we didn't find anything else and the patients come in with infection and all that kind of thing, then that could be a possible source of infection, couldn't it? But as you come further down, you start to see that you start to notice that the liver is there. And some of you have got very astute eyes. They may be able to see a little bit more than others. You may see there's a little bit of a kind of an enhancement difference between here and here. Straight away, there's a bit of a almost segmental enhancement difference. And what I'll do, I'll just do a bit of manual windowing. And you might feel that maybe in this area here, looks a little bit brighter for some reason, or that looks a bit darker, maybe a little bit brighter here. So for whatever reason, you've got, looks like some areas have got a little bit more fat infiltration than others. So something to think about. Okay, so you may have a little bit of fat on this liver, a bit subtle, I know, but it's definitely got a bit of an enhancement difference. But as you come further down, you've got to start thinking about what can cause abdominal pain. So one thing that can cause abdominal pain is going to be cholecystitis, so the gallbladder. How does the gallbladder look? So please feel free to tell me what you think. But as we kind of scroll through, you start to notice that that gallbladder looks a little bit thick-walled. We zoom in a bit. And then as you look at the fat around that gallbladder, you can see there's a little bit of fat stranding there and there. So look at the fat over here, very, very black, very, very dark. Over here looks very, very cloudy, very, very hazy. So that's not normal. It shouldn't look like that at all. And so therefore, this must mean that there's inflammation. So fat stranding results is because of inflammation. Now, you can't always see stones on a CT scan because you don't always get radiopaque calculi. You have to remember that a lot of the time calculi are going to be very cholesterol rich. And so you may have something that's isodense to the fluid, hypodense to the fluid, almost isodense to the fat, or you just may not see anything at all, but there still could be calculi that's causing some kind of obstruction. Sometimes you feel a little bit of irregularity going on within the liver, within the gallbladder. But on this one, I mean, maybe possibly there's some lower density within it, but you can't be 100% sure. But you've got the gallbladder sitting there, and then you've got to look at the intrahepatic duct. So you've got the portal veins, all these kind of hepatic veins, portal veins sitting here. And next to those, what you'll have are the intrahepatic ducts, and they'll be sitting like in this region here and this region here. But on this sequence, I mean, on this image, we don't really see much in the way of any low density adjacent to it, which must mean that there's no intrahepatic duct dilatation. If you had low density on one side of that vessel, then you're looking at intrahepatic duct dilatation. If you've got low density on both sides of the vessel, then you have to be looking at something like periportal vein edema, periportal edema. But in this situation, we don't have anything that looks like sort of intrahepatic duct dilatation, nothing convincing anyway, or not anything that we'd be particularly concerned about. But now, as you come further down, as we come back to this gallbladder, which clearly doesn't look quite normal, you can see that there is some fat stranding located there. And as you scroll further down, you've got the kind of the body of the gallbladder, and it kind of goes down to the tail. And as you come down to the tail, you've got these two hyperdense areas located within the sort of the neck, almost going into what is a CBD. And further down, actually, I mean, the CBD and everything else looks okay, but there's definitely what looks like a few calculi sitting there. So when you've got calculi sitting there on a background of what looks like an inflamed gallbladder, it's only really going to be one thing. It's going to be cholecystitis, right? But because we can't really stop there, we do have to look at everything else to be 100% sure there's nothing else going on. So we look at the pancreas, and the pancreas is sitting there, and that looks very, very normal. That looks like a nice feathery thing going a lot across the front. Look at the kidneys as well. Make sure there's no evidence of any hydronephrosis or hydroureter, and they look okay as well. There's no evidence of hydronephrosis or hydroureter. Both kidneys look normal. We can't stop there. We also have to look at the bowel, because, you know, that's the thing, like, people don't turn up like textbooks, and part of being a radiologist is that you're still looking for other things once you've spotted the first thing. What they often say is it's the second fracture that gets missed. You know, most of the time, it's not the first fracture that gets missed, it's the second fracture, i.e. what I'm talking about is satisfaction search. So we do have to keep looking. So if you keep your eye on the bowel over there, and we start scrolling upwards, just going through, making sure that the bowel kind of goes through, it's going through like this, kind of got this S sign for sigmoid colon, kind of going forwards. I feel like it's kind of going across the front, maybe. Yeah, going across the front like so, going across there. And then we need to find the descending colon, which is over here. Keep your eye where my mouse is, and we're still scrolling. Everything looks okay. So I'm going to just keep that there. Keep your eyes on the hit here, just to make sure everything looks okay. Okay, everything looks okay now. Coming up to splenic flexure, that looks okay. Going across the transverse colon, that will go right across the front. So just have a look, going right across the front. Yeah, perfect. Now we'll get to this area over here. This all looks all right as well. Doesn't look like there's much going on with regards to the bowel. And then you kind of have an overall look at the small bowel, and there doesn't look like there's very much going on there at all. So have we finished? I mean, we could say that we're done now. I mean, it's cholecystitis. What else do we really need to do? But actually, as you kind of scroll through from the very top, you might have spotted that there's this little region that is sitting over here. Can you see that? It's almost like a little crescent shape like this, yeah? And it's sitting just outside the liver, and it's almost pushing it in, right? It's causing a bit of scalloping of the liver. And that's not normal. And then you've got to try and look at that and see whether it actually continues with the gallbladder. I mean, maybe it could be the gallbladder that's sort of just continuing its way forward. as possible. So what we've got to do is make sure that it doesn't, we've got to try and make sure that it doesn't connect or does connect. There's a very, very important distinction to make. So if you keep your eyes there, and what we might see is that either it's going to close off and then you're going to get gallbladder, or this is going to just continue to be the gallbladder. So as we keep our eyes there, keep watching. You know what, I might just zoom in just to kind of keep ourselves less distracted from everything else that's going on this image. Go back to scrolling, scroll through. So there we go. So from the top, down, 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 down. And then it kind of looks like it finishes, doesn't it? And then you can see gallbladder wall sitting over here, can't you? And then that looks kind of almost separate. And then there's maybe what looks like a little tract there, possibly coming this way. There does look like there could be some sort of defect located within the gallbladder wall. Very, very subtle, but there does seem like there's a bit of irregularity of the gallbladder wall there, and what looks like some sort of collection or some sort of fluidy thing coming forwards superiorly and anterior to the liver, and to be more specific, we're probably looking at segment 4B of the liver. So that kind of opens up a little bit more. Okay, there's more going on than we initially anticipated. So now we're not just looking at a cholecystitis picture, we're looking at a complication of cholecystitis. What we're looking at is a perforation and a subsequent collection as a result of the cholecystitis. So I thought that'd be a really good case, because I think a lot of the time people will they'll see, you know, they may just like look at this one bit and be like, yeah, cholecystitis, move on. But actually, you know, this kind of patient may not get better, or may take a while to get better, because they've got a perforation and they've got what looks like a collection. And now when you scroll through, you can see, look, gallbladder, maybe with a tract there going that way, and then almost continuing into that kind of collection. And it's very unlikely that that's going to be a bit of like thin-walled gallbladder and thick-walled gallbladder. This is almost definitely going to be a collection as a result of a perforation of the gallbladder. And so what may need to happen is that they may need to go under ultrasound and try and drain this thing. So you can see how the management can change quite significantly, you know, depending on what you're seeing. And so it's really important to sort of ask the next question and the next question, and the next question, not just be satisfied with just saying, oh, well, you know, it's cholecystitis, what else do you really need to know? Right, so let's go on. Oh, so any questions at all whatsoever? I mean, do feel free to ask questions. The more interaction, better, really. Otherwise, it's me talking to myself, which I'm happy to do for those of you guys that listen to my podcast. I talk to myself all the time. All right, so we are going to be opening the next case, and I'm just going to click on this one here. So we just download all the images, and you can see that red line going right across the top. And then we're just going to look at the plain film first. So having a look at this plain film, I mean, they've got abdominal pain. That's the first thing to understand. They've definitely got abdominal pain, right? So it doesn't feel like there's much going on right at the moment. Let's have a look. Let's zoom in a bit, see if there's anything going on. Please feel free to throw in whatever you think may be going on. But bowel-wise, it doesn't look like there's very much dilatation going on. I mean, these look like these could be phleboliths, don't they? Yeah, oh, hang on, I didn't know I could make a full screen. These look like these could be phleboliths. Okay, we've got the urinary bladder that's probably sitting there, or maybe, I mean, it could be calcified fibroids as well, depending on the gender. But then you've got these sort of what looks like calcification sitting over here, and they look quite spherical. Could it be a bone island? Could it be something to do with the hip? Maybe it could be some slightly hyperdense fecal material sitting within there. I guess you'd have sort of the descending colon sitting along that region there. Can't really convincingly say that I see any evidence of any bowel dilatation anywhere. And the liver and everything else looks okay. So, I mean, the only thing that we can really say at this point, you know, for definite, that these kind of almost spherical lesions that are sitting over here. So this patient didn't get any better. So they needed to end up doing something else. So as usual, you kind of do a CT scan to try and see it. And I might have given the answer away already. But as you scroll through, we're scrolling through from the top. So first of all, what phase of imaging are we looking at? That's the aorta. It doesn't look as bright as the spine there. Fine, fair enough. Coming forwards, we can see that the portal vein sitting over here looks brighter than the aorta, so therefore there's more likely to be a portovenous image. There's a hyperdensity sitting over here, which is most likely to be an NG tube. You can see that sitting just within the proximal stomach there, so it doesn't really need to be expanded much more than that. So hang on. So then what you need to do is sort of scroll down. So let's just follow the rules. We go right from the very, very top and go all the way down to the bottom. And then kind of, you know, hopefully something jumps at you. If it doesn't, don't worry, we're going to go through it all anyway. So let's go from the very, very top all the way down. Like this, keep going, keep going, keep going, keep going, keep going, all the way down, all the way down, all the way down. Keep going, keep going, keep going, keep going, keep going, all the way down, all the way down. And then, for those of you that may see it, great. If you haven't, don't worry, we're going to go through it anyway in a kind of very systematic manner. So let's go from the very, very top. So first off, yeah, we saw the NG tube, and looking at the liver straight away, you can see some air sitting on one side of the portovenous system, and it's not on both sides, okay, and it's not within the portovenous system as well. So that's good, because if you had air within the actual vessels, you'd worry there's some sort of underlying ischemia. But like I was telling you earlier from the previous case, you can see how if there was intrahepatic duct dilatation, it would be on one side, because in this situation, it looks like there's air within the biliary tree, not fluid in the biliary tree. And you can see it's on one side, not both sides. So therefore, that's what the biliary tree would look like if it's got air within it. So this could be because this patient's had a previous cholecystectomy, previous sphincterotomy, previous surgery within the region of the gallbladder. So that's something to be like, okay, well, that could be what's going on. But so for those of you that did do that scroll through, you may have spotted that there is what looks like quite a lot of dilated small bowel throughout the abdomen. In fact, if you just kind of scroll through, so there's some dilated small bowel there. So let me just put my phone on silent. There's some dilated small bowel just over here as well. You can see that there's multiple loops of dilated small bowel. But then as you kind of scroll up as well, you notice that the gallbladder doesn't look quite right, does it? It looks a bit off. Where is the gallbladder? I mean, did they take it out? And as you come down further and further, you can see that gallbladder, which used to sit here, is still sitting there, but now there's like a defect. So do you remember with the last case, we had a defect somewhere else, but now we've got a defect on the medial side of the body rather than the lateral side of the body. The lateral side gave us a collection, and a kind of collection that was sitting in front of the liver, causing some scalping of the liver itself. But in this situation, we've got a defect that's sitting on the medial aspect. But then as you kind of look at that, it looks like it's communicating with, some of the adjacent bowel. So therefore, you're worried there's some sort of fistulation or some sort of communication with the gallbladder and the adjacent bowel. So what bit of bowel is this? If we scroll up and down, you'll see that this is the stomach. That's where the NG tube was. That's sitting within the stomach. You're going around, you're coming up to the pylorus, the duodenum, first part of the duodenum, and then it was around there, wasn't it? Look, first part of the duodenum, there seems to be a connection between what used to be the gallbladder or is the gallbladder and the duodenum. Now, how do I know that this is probably not just a diverticulum? It's so embedded within the region of the gallbladder fossa. It's very unlikely that you're going to get one single diverticulum and you kind of out pouches into that region. It just doesn't really happen. And so one thing to try and remember is that common things are common. And so therefore, you're not going to, it's very uncommon for a diverticulum to be sitting within there. More likely, this is a structure that's sitting that's now communicating with the duodenum. And as you can see, as you go further down along the first part of the duodenum, it looks a little bit dilated. Go beyond this area, which usually collapsed. Most of the time it's very, very collapsed around this region. And if there is dilatation, it dilates later. And again, you can see that, yeah, it does feel like it's dilating a little bit later. Let's zoom out a bit. And you can see that as you scroll through, this all quite dilated. And, we just got to follow it. And then you can see some hyperdense material there. Are we worried? It looks hyperdense, doesn't it? Then you kind of scroll through that way. You're scrolling through. So your eyes are around somewhere around here. And you're coming up to this region over here, maybe. I'm going to just keep my mouse, keep following. Look, that goes that way, all the way that way. We're coming up to this region over here, all the way. So we're going upwards. Oh, connects down here, coming all the way down. Oh, and then look. Looks like 1, 2, 3 very spherical calcifications sitting within that region. We'll go to the bone window and they look very, very spherical. Laminated or lamellated is what they call it. So there's layers of this calcification on the outside, 1, 2, 3 at least, which does correspond to the previous image where we had the X-ray. If I just open the X-ray, wherever that's gone, over here, and put that there, you can see, look, 1, 2, 3. We'll come back to the CT. Let's do it on coronal, just to be sure we look at the same thing. Look, 1, 2, 3. So obviously, depending on the angle that the X-ray was taken, you've got this. So someone said it exactly right. Yeah, well done. And you've also spotted the height earlier. Well done. So yeah, this is exactly. So someone has said what it is, and what it is a gallstone ileus. This is a gallstone ileus. So basically what's happened is that the gallstones that were sitting within the gallbladder have been there for so long, it's probably causing like chronic inflammation. And as time's gone on, it's kind of resulted in fistulation between the gallbladder and the first part of the duodenum. Now, if we zoom in, I'm going to just show you, look, there's that defect there, but on a different view. Can you see that? nice little defect there going like so, and those are the gallstones. So these gallstones have gone on quite a life journey. They've gone from here, this is all they've ever known, the gallbladder, and they decided to go on an adventure, and they've actually ended up causing a lot of trouble for this patient. And this is called gallstone ileus. And you won't really get a better picture of gallstone ileus than that. I mean, that is as textbook as it gets. And sometimes even the textbooks don't have as good an example of not only the plain film, but also the CT to go with it. So I hope that is useful for someone out there. Right, let's open. So we're going to skip case 3 and go straight to case 4. So case 4, let's have a look. So this patient comes in with left-sided weakness, right? So let's have a look at this one, and feel free to go through it. I'm going to go to the brain windows. We're going to scroll through and keep scrolling. So let's go from the top. So the brain parenchyma can be really, really subtle. And one thing you're looking at is gray-white matter differentiation, and it takes a little bit of getting used to. But if I was to zoom in to the brain parenchyma a bit further on, you can actually see that there is almost a linear sort of region over here, which is slightly hyperdense. That's going to be your gray matter. And then over here is going to be your white matter. Those are the motorways, the axons that all communicate with one another. And the reason it looks lower density than the other stuff is because it's more fatty than the gray matter. And the gray matter is quite dense material where, a lot of your thoughts and personality hides away within that area there. And the rest of it's sort of just communication between one another. And you do have areas of gray matter further deep within the brain as well, which I will try and point out as we go along. This kind of blackish stuff is going to be the CSF fluid. That's completely fine. And you'll see the lateral ventricles sitting here, here, and here, and here. And that's completely normal as well. So as we scroll through, we know this patient's got left-sided weakness. So let's have a look and let's see, has anyone said anything? No one said anything so far. That's fine. Let's kind of go from the very, very bottom. It's being a bit jerky for me, so I'm just going to download the images temporarily to be able to get a kind of a smooth, yeah, there you go, look how quick that was, and nice smooth scroll. And we're looking for left-sided weakness coming up. Haven't really seen anything, have we? Actually, maybe around that point there. So can you see there? Look at that little dot there. Can you see that? That doesn't look quite right to me. Let's zoom in a bit. So it looks slightly different. So then what you've got to do is look at sort of the similar area on the other side. And if you need to straighten out the brain, you straighten out the brain. So these are the Sylvian fissures. And then within there, you've got sort of the MCA. And that looks dense. And you can't really see anything like that on the other side. So it's clearly asymmetrical, definitely asymmetrical. And then as you come further up, you just do feel like there's a slight difference. So like, remember when I was talking about the gray-white matter? So there's kind of gray-white matter, but this looks a bit different. It looks a bit low density within this region over here. So in that particular instance, when you've got what looks like an MCA dot sign, it literally looks like a dot, because what's happened is you've got a thrombus, maybe in a small thrombus, but you're seeing it end on. It just happens to be the way the CT is taken, and you're seeing an end on vessel which has got a thrombus within it, giving this MCA dot sign. MCA dot sign basically means that this patient has got an underlying thrombus and will need to be thrombolized or sent off to get a thrombectomy. And if I remember correctly, I might have uploaded the CT scan for those of you that don't believe. Let's see, I think this could be the CT scan, so let's have a look. So case number 2. Maybe just another example. Hang on, let's open this one. Let's have a look. Let's go through. So scroll through. So look, actually, look, this is actually another example of the same thing. So if we kind of go from the very, very top. Okay, so look, this one has got slightly smaller CSF spaces, probably a slightly younger brain. And as you scroll through, almost identical in appearance to the other one, you're going to end up having a little dot that appears. So look, there you go. See that? That little dot there compared to there? Looks very, very different, doesn't it? Let's zoom in a bit. And just to convince anyone, but over there, compared to that, that looks slightly brighter. And that's how subtle these things can be, That's how subtle these things can be. And as you scroll through, you can actually feel as though you can see a bit of end-on vessel and then more of that vessel looking hyperdense going along that way. But on this side, it looks completely fine. Doesn't look like there's very much going on. And then, if I remember correctly, we do have the MRI scan for this patient. We will go straight for we can go for the SWI, I suppose. So if you look at the SWI, so any blood product will have a big signal void. So you just feel like a big void of signal with any sort of blood product, like slightly more acute blood products or thrombus. And you can see that that area there looks linear and very, very sort of hypo signal. And then MIP images wise, yeah, you can see that again. Look, very, very sort of hypo signal there. Let's look at the T2. We might see a bit of extra brightness within that region, which can be difficult actually on T2 to see like extra brightness, because you need that sort of dampening down of the surrounding fluid. And again, look, when you come up to the flare images, look at this area here compared to that side. So this looks brighter, doesn't it? So this doesn't look quite right. Then if we go to the diffusion weighted images, so what we're looking at in diffusion is looking for bright areas, because if you've got a bright area, that means there's restricted diffusion. And the way I try and explain this diffusion thing to you is that, like, for those of you that got kids, you know how active they are, right? So especially if they're very, very active, mine are 4 and 7. If you try, like, let's say they're getting into one of their little kind of moments where they really want to run around and jump and go, you know, have a great time. And if you were to hold that kid tight and say, you're not allowed to move, you know how much they wriggle and fight and all that kind of thing. That's pretty much what a thrombus is like. So if you're trying to hold a thrombus or an area where they've got a lack of blood going through, all those little kind of water molecules are restricted in their movement, and because they're kind of thrashing about, they've got energy that they can't get rid of, and they just shine bright, and that's what happens on the diffusion weighted images. There's no science behind that explanation, by the way, so please don't go and say that, you know, Imran said the science behind it. But look, on the DWI images or ADC map, you can see that there's low signal in the corresponding areas, right? And look how significant that area is. It's quite a big infight that we can only see a little dot for. So really, really important to, you know, really keep your eyes open and be open to the idea that there may be something called an MCA dot sign when it comes to this kind of imaging. And this particular image, we've actually got the MRI scan to prove what we saw. And I think with this particular patient, they ended up just having and continued weakness. They had really strong clinical suspicion. They thrombolized, and then they also did an MRI scan to try and characterize it more, and that's what they found. So did we have the, let me just see if we had the, sometimes you get an MRA, let's see if we had that, I can't remember now. If we haven't, sorry, apologies if we don't, I can't see it. Okay, fine. Let's go through to case number 5. Okay, so I'm just going to download the images and then change to abdominal windows. So this patient they were in a car crash, actually. I think they were riding a motorcycle. And what happened was they were riding the motorcycle, they fell off the motorcycle and literally skidded for like ages. I mean, it's not funny, I'm just saying, you know, it's not great, is it? So they were looking for, they had continued hip pain and they're looking for a fracture. So what we did the bone windows, and they were having right-sided hip pain. And what you've got to do is just try and make sure that the cortex doesn't look like it's broken at any point. And we may need to zoom in a bit. So let's zoom in a bit, just have a look. So I haven't checked the chat in a while. Nothing there. And let's see, nothing there. Okay, good. Hopefully no questions. Well, I don't mind questions, so feel free to ask. So you scroll through, and especially with the neck, you got to be really careful when you zoom in, because you just want to make sure that obviously there are fractures that are obvious, right? Like you're looking at a proper discrepancy, but sometimes what you get is like a kind of a slightly increased sclerotic line going like this, and that's like a really subtle impaction fracture. And I missed one. I missed it once actually. And then we had to do an MRI scan, and the MRI scan showed like florid edema within that region. You go back to the CT, there it was. It was like a subtle fracture. But here, actually, you know, I can't convincingly say I can see a fracture. Everything looks pretty normal. Inferior and superior pubic ramus look okay as well. Acetabulum looks all right. And then we've got to look at the rest of the osseous structures just to make sure, because sometimes you get these patients who've got fractures of the pelvis, right? Or they've got dehiscence of the sacroiliac joint. So one of the things to do is just to make sure that this and this are equidistant. They look about the same. There doesn't look like one's slightly bigger than the other. Also look at the trabeculation of the sacroiliac. There've been fractures that kind of really subtle that go all the way through and connect to the sacroiliac joints, and they can be quite difficult to see. So actually on this one, I haven't really seen much wrong. Has anyone else seen anything wrong? Okay, so let's go back to abdominal window. So then you've got to try and make sure, okay, so this patient's got abdominal pain. Let's go through the bowels. Let's have a look. Bowel looks okay so far. I can't see any hernia or anything like that. Everything looks okay. As much of the bowel as that we've got, we can see looks all right. Right iliac fossa looks okay as well. Yeah, not really much going on, but some of you may have spotted that there is some fat stranding located within the subcutaneous tissues over here and over here. Now, this is not the usual subcutaneous edema that you'd otherwise get with someone who's got heart failure, because this looks slightly denser than usual. And you can see there's a tiny little blob there, which you don't usually get with subcutaneous edema. And not just that, you've also got what looks like a elliptical, hyperdense region sitting within that area over there, just overlying the musculature. So that's probably overlying the TFL and the TFL and the lateral thigh muscle. And you can see it kind of causes an indentation over there. So this is something called Morel-Lovell syndrome, I guess, or injury. And so what's ended up happening is that you've got like a fascial plane between the musculature and the underlying subcutaneous tissues. This patient skidded. So what ended up happening is you kind of got a bit of skin that was kind of stuck on the pavement, and it pulled away everything away from the underlying musculature, and you get this shearing injury. And then because of that gap, it starts to bleed like so, and ends up giving this very sort of crescenteric appearance, hyperdense material. So this is actually hematoma. Not really much you need to do. I think once the clinical team actually did ask us to drain it, the patient was really uncomfortable, like really uncomfortable. I mean, obviously they're going to be uncomfortable. Sometimes what you may need to do is, if it continues to bleed, you may need to do different phases of imaging. This looks like a non-contrast study. If they get worse, you may need to do an arterial phase and a delayed phase, because sometimes you do get a little blush of contrast sitting within there, suggesting that they continue to bleed and they're probably not going to stop anytime soon, and may need to get some intervention as a result of it. But anyway, yeah, so that's a Morel-Lovell injury, and there's some really great articles and images out there, but I think that's a really good example of, I mean, I'm always going to say the good examples are my examples, aren't they? Okay, fine. So let me just download these images. So downloading, don't know what's going on there. Download. Okay, so we are now looking at, let's do this one. Go from the top. So again, it's abdominal pain. Let's think about what phase of image this is. Okay, so we're coming down, we've got a small hiatal hernia. Yeah, a bit of hiatal hernia, but probably not causing abdominal pain. It doesn't look like it's compromised in any way. And most of the stomach is actually sitting below it. I'll be careful about calling any abnormalities within the region of this region over here, because generally speaking, get a bit of folding of the stomach. I've seen a lot of people call tumors and all sorts of things there. I've got a very high threshold for calling anything in the stomach, and I think that's probably the safest way to go, because depending on what they've eaten, not eaten, how hydrated they are, etc., a stomach can look all sorts of weird. So I wouldn't go too far into it. Then you've got your aorta, which is sitting over here. Aorta is on the left, and you can see that looks kind of bright, but not as bright as the bone. And then when you actually look at the portal venous system over there, that looks slightly brighter. So therefore, this must be a portal venous system image. So then as you scroll through, you can see that there are some cholecystectomy clips. So they've had previous surgery, no cholecystectomy clips, any intrahepatic duct dilatation. So you can see a little bit of this low density adjacent to the vessels. And that's what I'm talking about when you're looking for intrahepatic duct dilatation. But it's much more obvious when you've got true pathology that's going on here. It's a little subtle, but that's going to be because we know that this patient had a previous cholecystectomy. So we're not worried about this particular biliary tract per se. Right, so now as we scroll through, the kidneys, they look okay. They don't look like they're obstructed at all. The pancreas, this feathery looking thing at the front, looks normal. Spleen looks okay. There's not a trauma scan, so we're not looking at anything that we're particularly worried about with regards to trauma. So let's go down to this region over here. One of the things I always do is just to make sure there's no hernias, because that could be an easy slam dunk diagnosis, but no hernias on this particular situation. So now we're going to do a bit of legwork. We've really got to get stuck in and look at the bowel. So let's follow, and we can see that kind of zigzagging thing over there. And coming up to this region, you can see that looks a bit fecally loaded. And actually, if you look at the fat around it, it looks very abnormal, right? And you're coming up to here, and it doesn't seem to be focally located within a particular diverticulum, because it can be quite tempting to call this diverticulitis, couldn't it? Because what you've got is essentially multiple diverticular, but you don't really have a focal diverticulum that's causing any sort of clear inflammation, but you do have what looks like a little bit of fluid around there, a little bit of fluid around there, a little bit of fat stranding around there as well. And as we kind of follow the rest of the bowel, we're going upwards, across for the sigmoid colon, then into the left iliac fossa, coming all the way up again, coming up to the splenic flexure, going across the transverse colon. Let's go transverse colon. Come on, go all the way across now, all the way across. That looks okay. All the way down, all the way down. And so we're sitting somewhere in the region of the cecal pole, and everything looks okay. In the small bowel, if we do one sort of cursory look through it, the small bowel looks okay as well. So as you kind of scroll through now, hopefully you can see that, man, there is a difference, isn't there, around the fat. So fat, 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 all looks okay. Get to here, it looks very, very hazy. So if this is not diverticulitis, if I'm saying it's not diverticulitis, then what could it be? So what's actually can happen to patients, but usually if they are elderly or someone said something, yeah, perfect, well done. Exactly right. So you picked it up, you know your stuff. So this is exactly what you said, stercoral colitis. So what can happen is that the fecal impaction, lots of feces just sitting there, can actually start resulting in inflammation itself. It starts to cause something called stercoral colitis. And stercoral colitis, where you've got impacted feces within the colon lumen and there's subsequent inflammation. And the interesting thing about this is that you can have someone that's got a defunction large bowel and you can still end up having this, because you end up you can end up getting some material being produced within the region of the bowel, within the colon anyway, because you've still got secretions happening, still got some impaction of secretions. And as time goes on, that can get really impacted, can get calcified, can get hard, and then they can end up having inflammation of bowel that's not even in use anymore over a long period of time. So it's quite a useful diagnosis to be aware of when it doesn't quite conform to, I say, ischemia, diverticulitis, appendicitis, epiploic appendicitis. When you really think about it, this particular image doesn't conform to any of those things, but there is definitely something wrong, and that's what it is. It's called stercoral colitis. Right.
So yeah. In the chat, Imran.
Oh yeah. Yeah, they said I've answered that. Oh yeah, there's a stercoral colitis, and I've said that's true. So I'm going to say I'll answer that live. Done. So fine. So yeah, well done. Whoever's picked that up, very good. Let's go to the next case. So first off, I think we have, let's go in the order I wanted to put it in. Let's download everything here and download everything here. Open that one, and we've got the X-ray. Okay, so first off, we've got a chest X-ray. Look at the chest X-ray. I haven't seen anything that's grossly abnormal. Everything looks okay. No evidence of any continuous diaphragm sign. Slightly rotated, because if you kind of draw where the clavicle is there, you've got your spinous process that is sitting there, and that really should be in the middle, because the clavicle is the most anterior aspect of your body, the spinous process is the most posterior aspect of the body, so that for them to get out of line with one another happens sooner than something that's right up next to each other. And that's why you don't use the clavicle with the sternum, because if you have something so close to each other, for them to go out of line with one another takes quite a while, right? Look at that. Whereas you've got something quite far from each other, they kind of get out of line quite quickly. So it's a really good way to try and figure out whether someone has got, their rotated film. But on this one, we don't really see anything grossly abnormal. Everything looks okay. I'm not particularly worried about this. But the patients come in with abdominal pain, and yeah, they've come in and got a CT scan. So let's go from the very, very top. From the very, very top here. Okay, so we can see a little bit of gunk within that lung area there. So let's have a look and see what's going on. Yeah, it's a little bit like the other patient we had earlier. Looks like there's a bit of spherical thickening of the bronchioles over there, maybe a bit of mucus plugging, a bit of atelectasis. So there's clearly some sort of maybe infectious process, like a bit of consolidative changes, a bit of gunk all sitting there as well. Now let's go back to the abdominal windows. Let's bring it back to the middle of the screen and go back to zoom, scroll. And let's go from the very, very top. And as you scroll from the very, very top, let's just do one run through just to see what's going on. So sometimes from the musculature of a patient, you can see that they're probably not that old, because you've got kind of a slightly older patient, they don't have, big muscular glutes and, abs and all this stuff. So the patient's quite young, clearly. They've got big paraspinal muscle, probably doing a lot of deadlifts and that kind of thing. It's quite a young patient. And as you scroll through, you may have spotted that there is this little dot here. Can you see that? Little dot there. And then you got that dot is very, very black. Very, very black is going to be here as well. Very black here, very black here. We know the lungs can be black because they're full of air. Everything outside of the body is going to be air. So anything that's kind of black on this picture is going to be air. So the lungs kind of finish there. And then you've got these dots. Can you see that? And another bit of low density there. So it looks like air. And if we go to the lung windows, you can see that, yeah, there is definitely some air that is sitting within the upper abdomen. So straight away, we should be thinking to ourselves that this patient has got what is called pneumoperitoneum. Something has burst, right? Something has burst, right? So first of all, what phrase of imaging? We've got the artery versus the portovenous system. The portovenous system looks slightly brighter, so this is a portovenous image. Scrolling through, the liver looks okay. The gallbladder looks all right, actually, doesn't it? And then we look at the kidneys, which are sitting here and here. Some of you may have spotted a simple cyst there, simple cyst, but actually there's not really much going on there at all. Everything looks pretty good. Interhepatic duct dilatation, no, maybe you can say a little bit. Can you see there, tiny bit there, but not enough to really think that this is going to be the underlying cause of the patient's problem. Spleen looks okay. So now we've got to do a little bit of work just to make sure that it's not the large bowel that has perforated. So go from the bottom, quite literally, go along like so, and then we can see the bowel going this way. Follow my mouse. We're going this way, scrolling around. We're going this way, this way, this way, this way, this way, this way. And then we can see that we're coming up to the descending colon, and you're coming up to the splenic flexure. And as you come to the splenic flexure, you can see there's a little bit of fluid sitting there, coming across to the transverse colon, which is here. We're going right across the front. Oh, we're looking like we're going behind some like slightly dilated bowel. Can you see that slightly dilated small bowel? And we're creeping around the back and then going down the side, and we're coming up to the cecal pole. And now we've got the, I don't know if anyone can see that, but I do wonder whether that the appendix is just sitting somewhere within that region there. But anyway, the large bowel looks okay. Doesn't look like there's any problems there, but you've still got a lot of air sitting within the upper abdomen. So even if you didn't see anything else, what you have to notice is that, well, you do have, what you notice is that you got lots of air within the upper abdomen, don't you? So the most likely cause of air from the upper abdomen is going to be a perforated duodenum, or it's going to be a perforated gastric ulcer. And so what we need to do is try and have a look and see whether we can find it. So if we come up to the esophagus, gastroesophageal junction, going right around like so, going right around like so, we're coming up to what looks like the pylorus, coming up to this region over here, and we're coming up to the duodenum. We haven't spotted anything grossly abnormal or obvious at this present time, but what we might need to do is go to the lung windows, and just to be 100% sure that we haven't seen anything anywhere. Why is it not working? So there, and lung. So let's see if we can find the stomach, going along like so, going right, and there you go. I don't know if anyone can see that. So I can see that now. I'm going to go back to, so if you keep it, can you see that little tiny trickle of air sitting within that region over there? I do wonder whether that could be the thing to be worried about. So let's go back to abdomen. And you can see there's a bit of outpouching, a little bit of air that trickles out that way, and you've got a little bit more air sitting over there. So I reckon that is going to be the source of it. That's going to be the source of it. So it's going to be around the pylorus region, a little outpouching there, coming out that way, that way, that way. And then you've got a few more lockets of air sitting within the upper abdomen. So this is most likely going to be a perforated duodenal ulcer. Right. So, and then obviously we've kind of gone through everything else just to make sure that nothing else is going on at all. Yeah, everything else looks okay. I don't think we're worried about anything else. So I think we might be running out of time. Let me just make sure. Yeah, so I think that was the last one. So I think that is the last one. Oh yeah, and then you know, for those of you that do want to go back and you are worried as to where you can't, if you can't see where it was, there it is pointed out nicely for you if you do want to relay and have a look at it later. So anyway, we've had a few good cases. We've gone through a bit of liver stuff, a bit of bowel stuff, and hopefully quite common findings. And I think if you are to go back from the beginning of us doing this series to now, you'll pick up little nuggets of information that are hopefully building on a bigger set of knowledge that will help you later. I hope that's been useful for everyone. I really do appreciate those of you that did turn up, and I think there was a slight mistake with the timing at some point, so apologies for those of you that weren't able to see it. Do please share it to people, you know, once it's online, to everyone, man, to your family, friends, anyone that may be interested, even someone that you don't like very much, go send it to them. Okay, cool. So Sada, I'm going to hand it over to you. Thank you, everyone, and I'll see you soon. Bye.
Thank you so much, Imran. I mean, it's a great, really good job with this, all of this, and you know, all of the previous webinars are on YouTube. So if you want, if you'd like to look at them, you know, just go into YouTube and search for Collective Minds Radiology, and you can access them there. All the cases are posted on the global community, so you should be able to watch them. I also sent the collection link in the chat. But thank you so much, Dr. Lasker. I will be sending out a collection of all the cases that we have reviewed today, and you know, CPD certificates, because you joined this live webinar. With the CPD certificate, I will also send out a feedback survey. And the reason why we looked at a couple more CT scans more than plain film was because of the feedback, pretty much. So whatever you say in the feedback is, you know, whatever we're going to deliver to you, because we want to bring as much value to you as possible. We really appreciate if you could take some time to answer this survey. But you know, to get more cases, make sure to follow Imran on Collective Minds. And remember that you can also add these cases to your own collection. And with that being said, thank you so much for joining live, and thank you for watching on YouTube if you do so, because we're going to upload this later. So thank you all for joining us tonight, and I hope to see you on the next webinar. All right now, bye-bye.